It's,
I was curious.
We're going live, just so everyone knows. We're going live. Thank you.
thank you.
I was curious in terms of the amount of time that was allocated to the policy committee and the personnel committee, where there was zero amounts of time allocated at that point. So I can't wait to see for Ron and how he handles that, and you know, and how Lucy handles personnel.
I think we just think what we're going to say. We don't say it.
Okay,
And then it's all done.
Jim, I'm hoping to allocate him a little bit of my time from finance.
Oh.
You know, perfect. Go right ahead.
Yeah, because we don't have a month end. Yeah.
Yeah.
We don't have a month end?
No, it's the 15th today.
Oh.
Oh, short
Right.
finance?
Actually, no, I have them ready.
Oh, I don't know. I thought Christine didn't know, but I guess
No, I don't think you do have them ready.
Can only hope.
I didn't see the word deferred on there.
But
So
you're right. You're right. So it is there.
that's
is?
right. I thought we might move through, well, we're going to move through finance real quick tonight.
Yeah.
We're gonna take whatever it takes, but we'll get through it quick.
We'll get through it quick. I also saw that our two presentations were going to take a total of 10 minutes.
Yeah.
Couple of minutes, aren't you, Jim?
I think they're 10 each. 10 each. Now that one is correct. 10 each. One an indented 10 and one is a.
Right. Okay. Somebody said, don't touch it. I'm not touching it.
You are live, so we are good on the communication side. We are streaming.
Excellent.
Hey, Cheryl, look where you're at.
Wow.
Oh, and there's flowers blooming.
Yes.
That is cool.
Excellent. Excellent.
We went on a Holy Land tour. So that was from Jerusalem.
Beautiful.
Very peaceful and serene.
Yeah.
Excellent. Looks like we have enough on. Good evening, everyone.
Good evening,
Good
Mr.
evening.
President.
Do we have any guests?
No guests.
No.
Excellent. We'll need the approval of the December 15th, 2020 agenda.
Motion to approve?
Second.
All in favor?
Aye.
Any opposed? Excellent. Approval of the November 17 minutes. Any corrections?
Move approval.
Second.
If no objection, we'll vote for approval of minutes. All in favor?
Aye.
Aye.
Those opposed? Excellent. COVID-19 update.
Good evening, everyone. Beginning on page 9, you do have the slide deck, and I'm going to try and share that out. Can everyone see it?
There we go.
So the
Now, yeah.
Good. And I'm going to skip a number of these pages. The deck is structured the way we've looked at it before, and I'm going to kind of move through it. And I'm actually going to try to stay as close to 10 minutes this month as I possibly can. I know we haven't done quite so well in the last couple months, but so I'm going to move through some of these slides because not everything necessarily changes a lot as we walk through this. Let's see. So as of this, we actually had 118 new cases today, and our positivity rate has now dropped to 11.8%. It has been dropping over the last week, We were hovering in that 15% range, 15 to 16% range for a while. We are now down to 11.8% by the IDPH website.
Marvelous.
Yes.
Excuse me.
This slide,
I'm sorry, I don't mean to interrupt. Do they think a surge is going to come, or are we going to get the Thanksgiving surge, or are we through that?
I guess I would suggest that if there was a Thanksgiving surge coming, I don't think we got hit with it. We got hit right before Thanksgiving. Things peaked. So usually Dr. Martell can just stop me, but it does not appear that we're getting hit with a Thanksgiving surge. And that's a good thing. Right now, the numbers are slowing down a little bit, and that's a positive indicator. As far as testing goes, you know, the number of tests continues to go up, and one of the reasons it's going to keep going up even more dramatically is now with the use of the antigen tests, which are being used in nursing homes and some of the some municipalities, some of the first responders, some schools are all looking at different ways of possibly using this. But in the nursing homes, we're twice a week testing for staff is now being required by CMS. We'll see the numbers of those shift. What we track, we don't get that data specifically posted from the state on the mix of tests. They do it at the regional level. And so those three charts at the bottom sort of show the molecular test, which is the standard PCR swab test, and then the antigen tests. And then that third chart at the bottom sort of shows for the region, those combined. And you can, right now, the antigen tests make up a relatively small percentage of the total tests, but we would kind of expect that to go up as time goes on, as those other sites start to continue to do more tests. I'm going to skip the R0. We look at this every month. What I will say is we are now below 1.0, which means we are theoretically reducing, the spread is spreading even more slowly. This next slide, the lab testing, this compares, we talk a lot about the volume of tests and the positivity rate and things like that, and the number of cases that we're seeing. The blue bar is the number of tests that are being done on a weekly basis. And you see we're sort of moving in that 10 to 13,000 tests a week. Right now we're around 12,000 tests a week. And then you can sort of see the number of cases on a weekly basis. And that's just sort of a slightly different way to compare that information for us now, to start looking at those two. I'm going to skip over testing frequency. Again, we're going to see more and more people having multiple tests. We've seen this slide and really that rapid increase in October and November. I would like to hope that we're sort of starting to see it slow a bit. And this epi curve also sort of suggests, you can see the first wave that was in the spring, and then you see our higher wave. This is based on date of onset of the cases, how many more cases we were seeing on a daily basis, and that is a wider band based on dates. But looking at our number of cases per week, the week just before Thanksgiving, we peaked at just over 1,900 cases in a week. And over the last couple of weeks, we've declined. We're now down more around 1,400 cases. So the numbers are still very high, but I'm encouraged that at least it's not appearing to be still on as much of an upward path. This is the positivity rate by month. Again, this is up through November. I would hope when we come at this in January, as our rates are starting to drop, we'd see November as having been a peak. Can't make that call out yet, though. This is the cases and deaths by age cohort. We've shown this to you every month. It doesn't change a lot, but we did you still see that the youth are still where we're seeing so many of those cases. Here's a slightly different way to look at this. This is for each month, the percent of the cases that are falling into each of those age bands. So as far as what we see, and you can see that even with the schools opening in the fall, some increase in the 0 to 9 bands and 10 to 19 in the 10 to 19, but not a dramatic change. So really, even with the schools opening, it's not like we're seeing this huge upsurge in the number of children being impacted. These numbers have been relatively stable month over month. But it's an important question to ask, and because people are so interested in what's going on with the schools and what the impact is in the schools, but we don't see it sort of overall really changing the age distribution of who is being affected by COVID in Winnebago County. I'm going to just sort of move through this. We look at cases by race and ethnicity. Early on, we did see that the African-American community was hit very hard. Now their numbers as a percent of the cases and their percent of the population are a bunch closer to what the distribution is. Similarly, the cases by age, by race and ethnicity, this really hasn't changed over the last couple of months. It's the Hispanic Latino population that is disproportionately impacted, is where we see that most dramatically. Similarly, we look at this every month to look at it, and age adjusting, you can really see how the Hispanic Latino population is really being hit hard by COVID in our county. Age and gender, we share this every month, and it hasn't really changed much. The statements on the slide are still the correct statements on the slide. When we look at deaths by race and ethnicity, just very briefly, the one thing I want to mention is when we first showed you this slide early, the African-American population was hit. The deaths accounted for 26% of the deaths, which was much higher than their percent of the population. Over time, the distribution of deaths now looks much more like Winnebago County does overall. It's getting close, it's much closer. It is what it is. It's not good, it's not bad. I wish the numbers were lower. I guess that's the most important thing. We look at hospitalization and length of stay. That has not changed over the last month. The issues relative, though, of hospital admissions and the ICU use and availability is something that we do want to make sure we continue to look at it. Again, so the chart on the left is admissions for COVID-like illnesses in the Winnebago hospitals. And you can see that, you see the first wave, we tended to have admissions sort of in the 5 to 10 people admissions per day. It was kind of in that, again, on the left-hand side, that first circle. And then if you look to the right side of that chart, that larger circle, again, you see higher numbers. And again, it's extending out over a broader period of time. So we continue, but that's directly going to impact hospital bed availability. And the chart on the other side looks at ICU availability. And that green line is the reported availability. And this is out on the IDPH website. They track this, and you can drill down to that information. The communities of concern, again, this is something that we share with you every month. I guess the only thing I'd call out to you today is that the mix of these communities, it has been shifting. Again, early on, they were all in Rockford, and now we start to see more in terms of when you normalize by the population. we see that mix changing. We're going to try to look at a different way to display this and show how those communities of concern have sort of shifted over time. I think that'll give a better picture. So when I come back and report this next month, we'll take a look at that. Looking at the schools, I think the only thing that I wanted to call out to you tonight is a number of the schools, because we saw that huge surge in November of cases going up, a number of the school districts have moved into remote learning environments. And there's a lot of discussions about who's out, who's going to be out, how long will they be out. We continue to work closely with the school districts, very closely. But we want to be able to make sure we're able to track, even with schools in remote learning, we want to still be getting that information and see how that impacts. But right now, we know who is out on remote learning. This chart we've shared in the past, again, it shows the increasing number of cases. This is cumulative of total cases. Again, we want to be able to drill down and look more closely at specific school districts and looking for impact. Looking at congregate setting, this is sort of, again, this is the mix. The only thing that kind of shifted in November is when we look at residents and staff in different types of congregate settings, the senior living group, which is like a senior assisted living or independent living locations, those locations did see a real increase with this second surge. And this next slide captures it a little bit as well. This is the cases over time in different types of congregate settings. The blue line is the skilled nursing facilities. Again, we shared this last month. That blue line shows that the SNFs got hit earliest and hardest. They continue to have the highest numbers, but you see that second bump coming in October to November with that increase. That orange line, the second one down, it shows the bump also in senior living settings with cases increasing. But overall, long-term care facilities, when you regroup them, they are accounting for a relatively small number of total cases, whereas early in the outbreak, we can see how they were hit hard early. And then as a percent of all the cases, it's declined over time. And now they're accounting for a relatively small percentage of those cases. We continue to monitor deaths associated by locations of concern. So whether they're in any of those congregate settings or whether they're in the community, again, reflecting the early impact on nursing homes. It was running at about 65-35% early on. And then with this second outbreak, though, what we've seen is a lot more deaths out into the community. We are now up to 311 deaths as of today, and we're right around 50-50. So, but the mix has shifted. I guess one of the positives there really is that we are seeing the nursing homes and other long-term care sites have done so much work to identify, capture, test, isolate, and limit outbreaks that balance is shifting. And then the last slide I was going to share with you this evening, just sort of as a different way to try to look at this data. When we look at causes of death, regardless of where they were, as far as the cases where COVID is the final cause, it's over 70% of those. 11%, it's listed as a contributing cause. And then 18%, almost 20% are cases where someone, it may not be listed on the death certificate, but they tested positive for COVID within 30 days of their death. And under IDPH direction, those are counted as COVID deaths as well. The next couple slides, again, are information that we've shared before. Things have not shifted a lot. And so I was going to wrap up right here. I don't know if anyone has any questions or not, but if not, thank you very much.
Okay, thank you. The vaccination plan for COVID-19.
Yes, that is me. Let me share my screen. Is everyone seeing it or no?
Not yet.
No.
Oh, I hope it's not frozen. 1 second. Try again. Oh. Now can
There
everyone?
you go. There you go.
A little technical difficulty there. So I'm Rebecca Lyons. I'm the Director of Public Health Emergency Preparedness with the Winnebago County Health Department, and I'll just be giving a very high-level overview of the Winnebago County COVID-19 vaccination plan. And I'll do a brief update on kind of where we're at with the vaccination process in Winnebago County. 1 second, sorry. So this plan was developed by the COVID-19 vaccination planning team, which falls under the planning section in our incident command here at Winnebago County Health Department. It consists of subject matter experts from the County Health Department, the UIC College of Pharmacy, Rockford, the UIC College of Medicine, Rockford, represented from the city of Rockford, specifically Rockford Rebounding Health Work Group. And we also have the village president of McChesney Park, who's also a practicing pharmacist at CVS. So the plan. The plan was developed based on the CDC vaccination program interim playbook for jurisdictional operations. And I apologize in advance, I did not send this out before the presentation, but I will be sending out an updated version for the board tomorrow. It was also developed and is currently being reworked to better align with the state of Illinois plan version 3. And again, this is an ever-changing document. We're constantly learning more information about the different vaccines that are becoming available and the processes for administering it. So this plan will be updated on an ongoing basis, and we'll try to post the most recent version we have available onto the website. So our plan is available on the website. That link might be wrong, so I'll update it when I send it out. Basically, there's a phased approach that ACIP provided, which is the governmental federal vaccine planning group. So it's 3 phases based on phase 1, where there's limited or scarce supply of vaccine. Phase 2 is when a larger number of doses become available. Phase 3 is when vaccine supply is more widely available. And phase 4 is sufficient supply of vaccine for the entire population. And this is the estimated doses per week per million. So this is across the United States, not specifically the county, and the weeks that they anticipate it taking to vaccinate all those priority groups. So for phase 1, phase 1A is frontline healthcare personnel and long-term care facility residents. Phase 1B is essential frontline workers, which includes police and fire. I'm sorry, I put the wrong picture over there. And C is people with significant morbid conditions and all older adults. So to elaborate more for phase 1A, when we say frontline healthcare personnel, our plan drilled down a little bit more into what that meant in the state. So hospitals will be the first ones receiving the vaccine. I'll get into that a little bit later, and they'll be administering to their ICU, ED, people with the most risk for COVID exposure in the workplace while providing services. Then EMS, and then down the line, first responders, clinics, dialysis. Sorry, the first responders, again, that is incorrect. I apologize for that. So EMS is separated out from first responders. So when they say first responders, it means EMS providing fire departments and law enforcement. Our clinics, dialysis centers, blood bank, public health professionals, long-term care staff, congregate care staff, home health, standalone ambulatory surgical centers, dentists, and the coroner and mortuary care and funeral services. For long-term care facilities, the CDC has a pharmacy partnership for long-term care program, which will facilitate safe vaccination of this patient population while reducing the burden on both long-term care facilities and as well on the health department as well. That would be provided at no cost to the facilities for end-to-end management of the COVID vaccination process. So they'll be in charge of both receiving it and administering it. In early November, 40 facilities in Winnebago County matched with Walgreens or CVS. And by long-term care facilities, we specifically mean those licensed as skilled nursing facilities or assisted living facilities would be on that 1A. And there we go. Phase 2 is people with moderate comorbid conditions. Obviously, I have to elaborate more on what constitutes severe versus moderate comorbid conditions. It also includes people on congregate care facilities, such as homeless shelters, group homes, and correctional facilities. So according to the state plan, they did not include correctional facilities in there. They identified them as a priority population, but they haven't assigned them to a phase yet. So we're currently working with corrections to develop a plan to vaccinate within their populations. Phase 3 is basically everyone else, so young adults, children, and jobs important to the functioning of society. And again, that would be those outlined kind of that weren't covered in the essential workers, which tend to be more like infrastructure, what we need as a society to keep running, whereas this is maybe universities, industry, parks and rec, retail, entertainment. Those would fall under phase 3. Oops, sorry, wrong screen.
I have a quick question because I was reading. So far, unless I misinterpreted, there's no children's vaccine for anyone. It has not been approved for people under 18.
No, not with Pfizer, which is the current vaccine available. So this is assuming that it will become available and be approved for under 18 under the structure.
Which is much later in the game.
I have a question. What would be the process when, as an example, we think we're in phase whatever? How do we register to receive the shot?
Yes, I will be getting into that in a minute. So if you just hold on 1 second,
Sure.
I'll describe it. So let me get to that in 1 second. Sorry, let me try to figure out how to change my slides. 1 moment. Oops. Okay, so as you might see in the board minutes, we have selected a platform to help with enrollment, patient registration and scheduling, a decision support system, appointment reminders, vaccine management, communications with state and federal reporting platforms, and communications with Epic, which is the EMR that a lot of our hospital systems use. We met with 6 different vendors in this space, and based on price and the features that it allowed, we went with Qualtrics as that. And we hope to or anticipate having registration and the decision support component of it available in January 2021. So that would be a link on our website where people can go and register. And they basically pushed them a survey determining basically a priority group that they could go in to schedule enrollment. So they'd have to go through that process before establishing an appointment. And I would also be able to do vaccine management through that, as well as provide appointment reminders, because this is a two-dose vaccine. So we want to make sure people come in for their second dose. So that's the system we currently have. Until then, we don't have a call-in line or anything for people to sign up. We've been receiving a lot of calls from the public with that regard, but there is no sign-up list for individuals yet. Our main push right now is to healthcare workers, and the healthcare systems are doing all the enrollment and registration of their employees and administering the vaccine through them. They are using our consent form under EUA, and I'm happy to discuss more offline the EUA process and what that means. But that's basically where we're at now in terms of the platform. And then up to date, so we might have heard Winnebago County is one of 50 counties in Illinois. Based on our death rate per capita, we were considered, to be the first priority group for rollout of the vaccine. It'll be distributed through our regional hospital coordinating center, which is over at Mercy, and we will be proportioning the allocation based on the amount of frontline workers at each system, at least for this first distribution. To Mercy Health, OSF Healthcare, St. Anthony, and Swedish American. And this round will only be going to the hospital systems, primarily because the way it's being received and the amount that has to be vaccinated and the time parameters for that. Again, the first one to come out is Pfizer, which passed the FDA this weekend, and that is the ultra cold storage, which is negative 70 degrees Celsius or negative 94 degrees Fahrenheit. So it is ultra cold storage, and Moderna is slotted to meet in the next week or so with FDA to be approved. So I expect to see more of that in the new year as we go forward. So that's where we're at right now. As Dr. Martell would say, it's like waiting for a baby. We're waiting for the vaccine to arrive and doing as much planning as we can, but it'll still be, working through everything as it comes.
Regarding the timeline, that a few slides back,
yep.
Is this considered week 1 or is it next week 1?
This is a tentative. This is the ACIP. So this is a federal timeline. This will be based largely, on how much quantity we're able to get and delivered. So it's not a specific timeline for weeks. This is just a hypothetical outline for it. But we'll be in phase 1A for a while, as you can see, the first month. And as we move through these phases and vaccinate more people, as provided we have enough vaccine to vaccinate them, we'll move on to the other phases. But again, remember 1A is a fairly large group, and phase 1B and phase 1C are as well. So this is going to be over several months. Again, this is liable to change as we are getting new vaccines available, like Moderna, which is a refrigerated vaccine, which we anticipate will be easier to administer and store. So this could be changing, but this is just tentative. There's no set in stone guidelines as to when these phases will happen. And again, it does make things a little complicated because, as you know, the holiday is next week. So that is anticipated to potentially affect distribution and administration.
And I think it's important to understand there is no, while they talk about the phases, you notice they don't say week 1 through 8 equals phase 1, right? Because first of all, just the logistical challenges on this ultra cold vaccine is, first of all, everyone we vaccinate week 1 in week 3 has to be revaccinated. So I know that it feels like, wow, we should just be able to roll this right through, and it makes it, those nice charts make it look like it's going to happen next week. I'm sure we're all reading the same tea leaves and seeing newspapers and hearing the same media reports, is that it's probably full vaccination won't be till the summer when we think we'll be in that kind of final phase. And of course, we already have people asking us if we're in phase 5 of Restore Illinois because we have vaccine. Again, it's good to be optimistic and hopeful. But I think that, again, it's going to be a process, and each vaccine product that rolls out, and I think it was Dr. Williams, the first 2 vaccine products will not be licensed for individuals under the age of 16, is what we understand. The Johnson & Johnson product, is being looked at for pediatric. Again, we're going to learn more about this, but even if you have a chance to read all of the emergency use authorization, we'll be posting the materials on our webpage along with the Qualtrics. Their CDC has come out with some FAQs, for healthcare workers that are considering vaccination, right? And the other part is that looking at the emergency use authorization, they're now calling it a fact sheet. So it's a little less than it was for H1N1 in terms of number of pages and reading level, but it's a much more extensive consent to participate. I also, I know that, I know Katie and Cynthia are both on, and we have them in our vaccine. They're giving out a little positive message to our healthcare workers who are standing up on the front line to get vaccinated and taking it for the team, for the rest of us, to start off this process. And I think it's very encouraging. And I think I know it's hard to be optimistic about so many things when Peter's talked about the number of residents we've lost and the continuing and ongoing infection, when all of a sudden over 100 a day feels like it's a good thing, right? Let's put it in perspective. But this is an incredible advancement in vaccine technology. And it is, we've got people that are really excited about getting this. And there's certain hesitancy as well, as, we're asking people to come under an emergency use authorization to basically agree to vaccinate, report their symptoms. And this first go around, we call it, and I know we're live on the recording, but I call this the vampire vaccine. That's kind of like a martini. It can't be shaken. It must be stirred ever so gently. It must be super cold, and you must be very gentle with it. And it has to be, and it likes dark. So within 5 days, you have to vaccinate. So this is I'm going to call our vampire martini vaccine. It's, to kind of keep everyone in a framework. And as the others come out, a little less logistical challenge, which will make it more accessible than to roll it out to what we call open pods and points of dispensing. So you can understand why the hospital walls are the first ones in. And throughout the world, I think it was very touching to see our first person in the United States for the nurses. I'm going to put one out for the nurses, was a nurse to get it. And in the UK, we know that it was someone in the seniors group. So that was good. And I thought I saw someone else that was kind of an interesting, each country is picking kind of the first representative to go forward in their system. So this is a huge advancement in vaccine technology. And when you think about it, the side effects that have come with other vaccines that we've seen to date, this has very, when I'm saying contraindications, I should say, not side effects. Everyone's going to complain of sore arm. You may feel a little, cranky after it, but the contraindications are almost minimal. And so again, there's no contraindication to using it in pregnancy. We've heard a little bit about the allergic reaction, but again, not something in the vaccine components, because it almost has nothing except lipid. And of course, anything that makes us fatter, we won't want, but okay. But no latex in it, no preservatives. So this is a very relatively, advanced vaccine profile that we have not seen forward. So it kind of does, for those of you who are public health history buffs, go back to the days of polio. The reason we have 2 types of polio is there is a race to develop a vaccine. And it's those moms in the March of Dimes that got us that vaccine. So Warp Speed, March of Dimes, we're all getting there.
Very good.
Excellent.
Jim Powers, I had a question. First of all, Rebecca, a really nice presentation, so thank you. I did have a question for either you or for Dr. Martell. One of the things that we hear about, at least I'm hearing about nationally, is about fund availability to make sure that the distribution of the vaccines can take place. Do you have any thoughts or any information about the funding that will be necessary in order to be sure that all of this can be accomplished?
I'll let Dr. Martell take that one.
Okay,
which is fine. Rebecca, really good job. Thank you.
Yeah, and we're, again, when you talk about fund, as you know, the government is going through its final debates on any of the stimulus packages, funding for the vaccine rollout. I would hate this to be the rate limiting step. I think that when you look at where the investments have been in all of this, I'm going to put there's a lot of in-kind going on. How do I say that politely in a way that doesn't, we certainly will be looking for additional funding to support efforts. I thank the Board of Health for their consideration of a software application to support this effort. I mean, this is not an easy thing to consider, but remember the hospitals are using all of their staff to vaccinate their employees, right? So there's no kind of outside, we're all pulling that wagon together. We're working through a training program with our EMS to support it. The challenge will be is if something breaks down in the manufacturing. And so I think that we've really got to make sure if there's an opportunity to implore our elected officials to support funding of these initiatives, both whether you call it, there's a variety of packages, funding of local units of government right now. Remember, our city and our cities have not received their usual sources of tax revenue associated, and that funds some vital services. I'm going to call it the pandemic, the small business loans and things for some of these businesses that need to hang on. So while we're in a phase, the next 6 months is going to be really rough for them still, right? We're not out of the woods by any stretch of the imagination. And then the third thing, which is the additional burden, expense, and cost of just doing all of this.
That's what I was referring to.
Mm-hmm. You mean in terms of grant funding?
In terms of what I'm hearing about federal funding,
yeah,
for the cities and states, and how that will affect the funding for the distribution.
Well, and I think, how do I say, we have not heard about any funding. I mean, they keep telling us there might be some. So I think most of us are preparing to use our existent leverage everything we can to get it into our communities and to vaccinate the population. And I think that's where so many of these efforts will be. I'm going to say it's going to take all of us. It's going to take a village to vaccinate the village. We're going to rely on a variety of methods and people and institutions to assist in this process. And so it will be a huge global and a local response. But funding certainly will support, but it should not prohibit us at this point from moving forward with, moving with what we get. I'm going to be honest with you. When I put out a call and said, I have to laugh, we have to get gloves for dry ice. And I said, you can't buy them right now. It's almost funny, right? And they said, well, these are the gloves. We'll get them from the fire department for you. I'll wear the thermal gloves, right? And so, I think that's the kind of support we have to give. We've got to be creative in our thinking as well. Leverage our existing resources. And then if we get some additional, use them wisely to get this effort off the ground.
Okay, thank you.
But on that note, though, remember, you've got a lot, we really have to make sure our legislators are aware of the need for funding at so many levels for our communities. We know that bump and that stimulus kept a lot of families out of poverty. We're still our food pantry service with the Salvation Army. When I look about, they're still doing over 1,000 food, distribution on a weekend. We have people that are really suffering through this. Their employment's been impacted. They are supporting each other in their homes where, they can't go out and pick up some extra hours, maybe waitressing or doing some of that kind of work right now. So this is a really challenging time, and we need to really work with our government to make sure that they are looking at all aspects where there's been economic impact that's really impacting health in the long run. So whatever you can do, keep those, make sure we hold our elected officials accountable for getting something done before the holiday closure.
Excellent. There's nothing really for president's report, committee reports, the executive committee. I don't believe there's anything, and we can move to finance. If John is on, I thought he fell off.
I am on. I've been having some connection problems, but we'll see if we can get through this.
You need to get a new phone with the 5G. That's what you do.
We'll look into that. Thank you. I need a motion of the approval of the Finance Committee minutes from November 9th, 2020.
So moved.
Do I have a second?
Second.
I have a motion and a second. Any questions or discussion? If none, all in favor, signify by saying aye.
Aye.
Opposed? Minutes are approved. We will move into financial statements. November 2020. The first is for expenditures incurred in the health fund for the month of November in the amount of $934,270.01. Do I have a motion to approve?
So moved.
Thank you. Do I have a second?
Second.
We have a motion and a second. Do I have any questions? Do you have any questions or discussions concerning this? If none, all in favor of approving signify by saying aye.
Aye.
Opposed? So passed. Statement of fund balance. For the second month of year 2021. That's there for your information. As you can see, we went from our initial balance in end of September, $10,424 and change to, I'm sorry, okay, ending balance of $9,914,000, decrease of about $500,000. We will move into our balance sheet, which can be found on page 30. Excuse me. Let's see. We also have the financial review. I apologize. I missed that. Page 29 for the month 2 of Winnebago County's fiscal year and also the 5th month of the state of Illinois. We have the revenue and expenses for your perusal. If anyone had any questions, bring those up. If not, we'll move into the balance sheet for November 2020. And mine is marked preliminary, Jim. This is still preliminary because of our date, the 15th.
Yeah, I estimate expenses because it hasn't gone through audit at the county, but we try to do the best we can. So
Okay. That's what I thought. Thank you. Jim, do you have any comments on this, or does anyone have any questions for Jim concerning this?
I mean, as far as I see it, we're down about $500,000 through 2 periods, but we'll be posting the real estate tax levy quarterly payment next month. So I think we're pretty much right on track. We're probably at about a maximum as far as our cash position right now, because we just, we received our local Cures first reimbursement, which was nearly $500,000, and we're pretty up to date on a lot of our collections. So, absent of getting additional funding, I'm thinking we're peaking right now as far as our cash position. So.
Okay, thank you. We will move on to 2E, which are bank reconciliations. We have 4. This is for information. We have the general account, the lead account, the abandoned properties account, and the state of Illinois e-pay. Does anyone have any questions or concerns concerning those amounts of those reconciliations? Okay. If none, we will move into F, which is the revenue and expenditure report. Give me a moment to into that. And Jim, anything you want to point out concerning that?
Just we had 81,000 from October that weren't posted that are buried in these numbers, and I think we're pretty up to date with November's, and I have a correction going in for, again, I mentioned it last month as far as the budget, as our budget revenues, the same as what they were last year, and our actual revenues are budgeted like 14 million 485. So or four, yeah. So we're going to make those changes, but because we are not projecting a deficit of 2.6 million for this year, we are projecting a very modest surplus of 56,000.
Thank you. We have the public health emergency reserve graph on page 48. As you can see, we are holding steady, a little bit of a bump from October. Still are hovering just shy of about $10 million in our emergency reserve. And we have accounts receivable.
I don't have that ready for
Okay.
November.
I did not say thank you.
Okay.
Okay, we will move on to major expenditure requests. The committee meeting, we had 2 major expenditures in which Finance Committee approved a motion to advance those major expenditures. One was for vital records and one was for Health Administration for the Northern Illinois Public Health Consortium membership dues. As I said, Finance Committee approved the motion to forward these. Do I have a motion to approve?
So moved.
Thank you.
Second.
Do we have any questions or discussion concerning these 2 expenditures? If none, all in favor signify by saying aye.
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 Aye. Opposed? If none, so passed. We have a major expenditure in the health promotion to Periodontics of Rockford. It's a reimbursement for Ryan White Dental Services in the amount of $3,141. Do I have a motion to approve?
So moved.
Second.
Thank you. Any questions concerning this? I do. I was having a hard time figuring out how many patients this was that were treated. Do we have a breakdown of that? Was I misreading that?
I can give you, if you recall, in previous meetings, we used to pay pool administrators under the Ryan White program. And apparently this particular dentist did not provide their a timely invoice for work that was done on that. So we didn't get our initial reimbursement through Ryan White. So I think Todd Kisner had filed through the Court of Claims, and they did the work in earnest, and now we are through the Court of Claims, and it's on deck. So in order to preserve that relationship for that particular dentist, they wanted to push this through. So Todd Kisner, do you have anything else you want to add to that?
Yeah, so this is actually one client that had some extensive dental work done. As you can see, it's the periodontics. So we were talking some oral surgery and stuff like that a typical dentist couldn't do. And so this is over a course of several visits to complete the work that they needed done. So, they're a group that's, oral surgeons are a difficult group to, not to work with, but to access in our Ryan White program. So, we've been working with them, explaining the process and stuff. And so we just felt it's in the Court of Claims, and we'd like to preserve that relationship because they're a dime a dozen for oral surgery. So.
Yeah, periodontist actually. I was just curious. It appeared that it was a single patient for no more than a couple. I was just concerned. Thank you.
You're welcome.
Do we have any further questions concerning this expenditure? If none, all in favor of approving signify by saying aye.
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 Opposed? So passed. Bear with me. And our next major expenditure is for, you pronounce Qualtrics.
Qualtrics.
We did an electronic poll with the Board of Health where it did pass. It was in the amount of $540,500. This was for vaccination management software. This is approved by the board, so this is strictly for information. Sandra, could you possibly go into a little detail on what this is going to provide or how it's going to streamline? I know you and I spoke about this earlier.
So actually there were, when we started planning for the vaccination, we recognized there were a couple things or concerns that we had. One is when you start going out to, I'm going to say the community to engage patients for enrollment, we knew that we needed a system that would help us prioritize based on really criteria. As you saw from those phases, as you guessed, we're already getting requests for vaccine and put me to the front of the list, right? Which is a challenge, right? So part of it was we needed a system that would help us to register and essentially allow for patients to register themselves as much as possible. And then really kind of a booking and a prioritization system. So as vaccines became available, it would allow us to slot them into those appointments. So for instance, if we have 200 doses of vaccine and we have 500 people, that system would then go out and pull us in the most prioritized 200 based on the criteria and be able then to put them into that appointment. They would then be able to, through either a mobile device, it can also do paper. So for clients that need paper device, we can do it as a back office or a front end. We can do it through a call center. Would then come up with their reservation for this particular vaccine. We needed a much more robust system. We looked at using the back end of our, I'm going to say the tire drive philosophy, Todd Marshall, and looking at how do we book and book tires. And we said we're going to need something much more complex because it needed to be able to also upload to the vaccine immunization registry. And it really became important to understand as we looked through our whole team was a system that was not owned by any one particular hospital, that it had to be able to, that the patients really own their data. So not only did we have that initial dose, but also tracking the vaccine type they got and when their return visit is scheduled for. Because you heard about Pfizer's a 21-day, Moderna's a 28-day, and who knows what the next one will be. So managing all those various types. The other part that we looked at was the event. Most vaccine adverse events are reported out in a passive way, right? You wait till the event occurs and then they go and they start to take the history. We felt another part was with this kind of newer vaccine and building public trust, that there would be outreach throughout the process about their experience, right? You know, how are you feeling today? So they start with more of an active outreach approach as well to individuals to find out how they're doing post-vaccination. And are there any complications or side effects we should be aware of? And I think the real part was that prioritization, that we recognize that typically people who have means and capability would be able to get on systems and get appointments scheduled ahead of others who might have more access issues. And I think the equity lens became so, and with this system, we really felt a system, and then this system in particular would help us be able to demonstrate our commitment to that piece. So for instance, if we are going to target vaccination of a particular zip code based on that high rate of disease, then it would preferentially select that zip code for prioritization for vaccination. And then as we got doses in, be able to do that and really kind of target that kind of sense of, so that it wasn't the person who could dial in fast, just like for a rock concert ticket. The system would basically waitlist it, right? So if I'm not in a priority group, it waitlists me until it's appropriate for me to be put in. Because we also know that the public is very interested and they want to make sure that they get a dose and that we're reserving a dose for them. So we had this vaccine management, we had the reporting and the prioritization for the patients, as well as ownership of patient data that didn't reside in any one particular insurance company system or We know that most of our systems use Epic, but in order to use Epic, they had to have been partner with one of them. And we recognized that people wanted some flexibility. So, we looked at what we could currently get in the market, what was out there. And we reviewed and we felt that this was a system that would support our objectives of this vaccination campaign. They also will be, which is kind of an afterthought, but a slick event, will be some ability to do some dashboarding about community uptake of the vaccine. And we know that when we start telling, just like we've done a couple of media messaging and posting about when we talk about how we're doing with testing, or even the reports out when we don't report out what our positivity rate is or how many new cases, people are calling and they do watch that data. And so there was not going to be a statewide database or even a net, to start out, but our county data, kind of what is our vaccine uptake for our community? Kind of like let's get to the finish line, folks. So to provide some more transparent outward look. So this is an exciting thing. We expect to stand this up, as Rebecca said, we've told them that we need our first ability for people to be able to start registering by January 1. So because we know the interest is very exciting. It's hard to believe we're already in the holiday week already almost. So we're moving forward. We felt it was a way to support our effort. It's going to be one of the largest efforts I think we put forward. I think I was watching something and trying not to get too overwhelmed by the thought that this will be the largest vaccination effort ever mounted in the history of the world. So I try not to think like that. So, but it will be a significant effort that we mount forward. So I also think that in terms of looking at systems, we can't forget, I know Peter's online as well, we're continuing with our community health assessment, and Qualtrics is one of the vendors and system architects that are using a lot of community dashboard work. So we felt that this was a way to start also. While we have one effort and initiative that we'll see how it works and supports our community, we may have an opportunity to move beyond the pandemic and move on to our community dashboard.
Thank you, Sandra, very much. And we appreciate all the work that went into going through these various software possibilities and narrowing it down to this. Thank you.
We hope maybe at the next board meeting, if they've got their front line up, we can kind of walk you through what that registration piece will be looking like, kind of from the backside.
That would be great. Thank you. We'll move on to 4, proposed contract and agreement. It's found on page 28. That is a HealthWorks transition to managed care, which is just a continuation of our HealthWorks lead agency grant. Does that require a vote? Or is that information only, I believe?
Where are you, John? I'm sorry.
I'm sorry, I'm on number 4,
Page 98.
Yes, that's what I have. Yeah, remember. I'm sorry, there was something else.
No, there was a grant. Yeah, that's on.
Yeah, the DCFS HealthWorks Transition to Managed Care Center grant, but that's just a continuation of a grant. That does not require a vote, does it not? Or an approval?
The original grant was with the Department of Children and Family Services, and they've now moved it over to their vendor under the managed care, which is Centene Illini Care.
Just FYI.
Did we do item number 4 about the various contracts and agreements?
No, we're moving into that now.
Okay, thank you.
Yeah, I apologize. Yeah, I'm sorry. That was 5 for grants. I was ahead of myself. We're moving to 4, which is the proposed contracts and agreements. The Finance Committee approved a motion to advance the 3 proposed contracts and agreements, items A through C. The Erickson Agreement, the Rockford Park District, and the site agreement for the COVID-19 vaccination based community administration. Do I have a motion to approve?
So moved.
Second.
Thank you. Any questions concerning any of these contracts? If none, all in favor of approving signify by saying aye.
Aye.
Opposed? So passed. All right, we'll move now into the DCF as health work transition to managed care, which is an information only contract continuation of our HealthWorks led agency grant. So that's for FYI. If there is nothing else with finance, we are concluded.
Excellent. Thank you so much.
Thank you.
Policy.
I'll try and stay within my allotted time
Here.
of 0. I would
Okay, you're
entertain
done, Ron. You're done.
Yeah, I'm done already. I can entertain a motion to approve the minutes from our December 9th meeting.
So move.
And there was a second, I think.
Second.
Yes, thank you. Any corrections? Okay, all those in favor?
Aye.
Aye.
Opposed? The only thing we discussed at that meeting was the variance applicant's request to switch from a surety to insurance, which raised a whole bunch of other questions that we asked Todd to go back to the applicant and try and get answers from somebody other than his engineer. We don't have the expertise on the insurance, so we need more information as to what the policy would cover, how we can protect ourselves if non-payment of the policy, how we make sure the policy continues, etc. So that's where we're at with the variance request for the holding tank in McChesney Park on the Harbor Oaks property. And that's all we have.
I have a quick question about that. Isn't that the holding tank is, am I wrong, supposed to be temporary until they can get into a septic system or?
They can't have a septic system. It's not going to work anymore there. So the holding tank is going to be it. Otherwise, they can't use the property.
Oh, okay.
And it's right on the river, which adds to the whole jeopardy of something happening. And that's why we're talking about the surety or the insurance or some way of protecting the people around there and the county from liability.
If I
It's not ideal, but it's the only way to use the property.
I can just add on to it where we're at with the status on that. I verbally have talked to the owner and to the engineer on this property. I have a drafted letter that went to Dr. Martell administration and the state's attorney's office for review. But basically, we just to recap, we did approve that variance for the holding tank back in October. There were some stipulations to it. One of the stipulations was obviously that surety bond. They requested, or they're proposing liability coverage, an umbrella liability coverage from their insurance instead of that surety bond. And again, yes, brought up a lot of questions. And so basically the drafted letter is basically saying that what is this liability insurance cover? Will it cover the potential pollution releases if that happens? Obviously, we need a copy of that directly from the insurance provider, what it pertains to. Obviously, we want to make sure that we're listed as also insured under that policy. I think that's the route we were going with. Also, we want to make sure this insurance policy is for the entire life of that holding tank. And we want to make sure that we have some documentation on an annual basis that is being covered. And also maybe some kind of agreement that could be recorded on the deed through the recorder's office. That's basically the gist of it right now. But again, it's in a draft form, but we'll get that out. So. Thank you.
obviously, we're going to be talking about this again and maybe again and again, but we'll see.
And actually, the drafted letter does kind of say that there could be further questions. And
Absolutely.
I can see this rolling out. So
Yes.
Ron,
Mm-hmm.
Angie,
Yes.
you know, when I started on the county board, we have an incident out here in the northwest end of Rockford where there was a break in a sewer that caused so many problems, and Todd can relate to it, and because of neglect. This holding tank is exactly what it is, a holding tank. And it can burst at any time. There's no limit to it. It's only from when they are under construction. So that means it's only for a period of time that that holding tank is going to hold. If that were to leach out and start, that's a populated area over there. And if that starts leaching out, you're going to have a lot of wells that will be infected. Am I right, Todd?
yes, Angie, what it would basically do, and I hate to say it, you know, solution to pollution is dilution. And what it would do is pull it towards the river, which would go down to, I hate to say it, down to Ogle County, but obviously we got
No, well, then there's no problem.
I should have said that, but truthfully, the current will pull anything that is leached out from that holding tank. The river will pull it and send it downriver. Now, that's one of the things with this agreement is ensuring there's inspections. I got to do that. And we could set an inspection every month. Yeah, I mean, or something like that. So if there is some type of release, we'd find it, you know, maybe every 30 days, which we could do that as a quick stop on a, you know, but a good point, Angie. Yes, there is concern. Obviously, there will have to be some engineering to that to maintain some kind of brace, ensuring that this tank will not float, which will snap the pipes, which will then potentially leak. And that's really the concern. So
yeah, I was reading the note from the lawyer, and he said he was gonna put in some anti-float devices and other things to try to stop it from doing that. So you're saying that once this holding tank is put in and they build a home, it would always just use a holding tank?
that is correct. We were reverting to the state code. That's what it did. Our code basically says, and good point earlier, you did say, isn't that usually used for temporary until sewer comes? That is true. But in that variance, it does say if sewer does come, that he has to hook up. But referred to the state code, which does allow holding tanks.
Todd, I got a question.
Yeah.
What about timeline for when they have to have it pumped?
Okay, that's all the stuff that we're going to put in the agreement. There's going to have all the bells and whistles. What I mean by that, there'll be alarms that'll be set off. Then he'd have to have a contract with that pumper. He's going to have to show us receipts. If the daily flow on a 3-bedroom is 600 gallons a day, so I think they're proposing a 4,000-gallon tank. So he'll be pumping it quite often. So is it financially feasible for this owner to do this? That's his decision now. But the bells and whistles, the alarm will go off. We'll get those receipts. We'll have to keep track of it because we're going to put a meter on as well, too, on the water. He's got public water. We're going to put a meter on that. So they better justify, we'll know if there's leakage. So they'll be reviewing that on a monthly basis with inspections. I think we got it covered. I really do.
Thanks.
Of course, we don't consider in all our conversations so far the extra burden on the department for this one piece of property.
Right.
That is true. And that's probably what we're going to have to calculate in, making sure that nothing is happening and how often we do stop there. You're right. And maybe there should be a charge to that. And
well, I'd love that. I think there should be.
I agree. And we do have, and that's operational agreements that we do have on aerobic units, on engineered systems that we do put in place, that we do check on a regular basis. It's usually every 6 months. For this situation, maybe we should get a little closer, time duration, but
Yeah, because this, and again, the environmental damage, I mean, this is one of those things, it's very hard to calculate the impact should there be an excursion.
true. And one of the concerns I do have, obviously, we'll be looking at the water meters compared to what they're pumping out and how often. Again, they say the rates are about 600 gallons a day. I think that's a little over, but the one thing I'm really concerned is they're going to redirect certain types of water, like laundry water, which needs to go to the septic. They're going to try to divert any type of water possible. I'm assuming once they're starting to see the cost of pumping and all of that. That's truly, we got to keep an eye on that.
That's all, Mr. President.
Thank you.
Thank you.
Personnel Committee.
Okay, we actually had a meeting haven't had one for a long time. First thing is to approve the minutes from the December 9th meeting. Is there a motion to approve? Is there a second?
Second.
Okay, all in favor?
Aye.
Okay, the only other issue we had was the director's compensation analysis. I'm going to turn this over to Sandra to kind of talk more about that.
Yeah, we had done we presented to the personnel committee a reevaluation of some of our key leadership positions and proposed a salary adjustment to bring them in alignment with the existing personnel.
Okay, do we need to do anything on that any further?
No, you recommended approval.
We just recommended it, so we're set on that.
But you need to motion the board.
I need a motion. Okay, is there a motion to approve?
I move approval of the changes in the compensation.
Is there a second?
Second.
Okay, everybody all in favor signify by saying aye.
Well,
Aye. Oh, I'm sorry. Any discussion?
yeah.
Sorry. No discussion?
No discussion.
Okay, now, everybody in favor?
Aye.
Oh, opposed? Abstentions? Okay, and that's all we had.
Okay, I have just one statement. So I'm looking at these rates and the date of hires and things of that nature. Is there any way we can put in something automatic so that in the future, we don't have such a discrepancy from people that have been here from new hires? Because when we hire new hires, we look at average salaries and things of that nature to make ourselves competitive, but we don't do anything retrospect for the people that we already have, or do we?
So, Dr. Williams, it really, and we've had this conversation as part of the committee, is that promotion from within usually ends up in a deflation on the salary. So I think if the personnel committee wants to take a look at how what the promotion rates are, then we could take a look at that. In all three of these situations, they were all promoted from within.
Yeah, that's what I was saying. I understand that. I read the minutes and understood the concept. I just know that, in every organization, it's hard to sit there and do that, because you really take a look to be competitive when you hire, but when you promote from within, I don't know if we actually look to see what the going salary is for once you promote that person. You know what I'm trying to say?
Correct.
Okay. All right. That was just because it happens every organization.
That's why it's time to take a look at it.
All right. Do we have quality with no meeting? Do we have any new business or correspondence? And I don't believe there's an executive session.
Nope.
If not, we need a motion to adjourn.
I move we adjourn.
Second.
Second.
All in favor?
Aye. And have a Merry Christmas.
Merry Christmas.
Everyone.
Christmas.
Everyone be safe, and I'll let you know how much the vaccine hurt once I get it.